Thank you, Dr. Axman, for that wonderful introduction. I don't know if I deserve it, but thank you so much. Okay, so this is a lecture that is near and dear to my heart because it's something that I've been doing for a while now, treating these difficult Charcot cases. There's a lot of different techniques in trying to fuse these patients and trying to get a stable foot. So this is just something that I do for some of these difficult cases. These are my disclaimers. Okay, so you probably have had a slide like this in the beginning of the lectures, right? There's 30.3 million people in the US affected by diabetes. 7.5% of those eventually will develop peripheral neuropathy at one point in their lifetime, as well as Charcot neuropathy. And this leads to the progressive subluxation that can lead to a rocker bottom deformity if the midfoot is affected. And if the ankle is affected, it can lead to an unstable varus or valgus deformity. And so this is one of my patients that at the end we have a really good outcome of her. She ended up healing 100%, but her ankle is completely affected by Charcot neuropathy, right? And she had been told several times that she will probably need an amputation, and in fact, she already had an amputation to the other side. So these are really limb salvage procedures that we have to do. So they are people with Charcot neuropathy have 7 times the risk of amputations than patients with neuropathic foot ulcerations, and 12 times greater if they have an ulcer secondary to Charcot deformity. 13 times more likely if they're over 65 years of age with ulcerations. And the mortality rate following an amputation is documented at 50 to 60%, okay? Does this go forward? Oh, sorry, okay. There we go, okay. Okay, so this is a nice little graph that's been shown in a lot of the conferences that I go to, and I really like to show it just because it shows the severity of what Charcot neuropathy can do to the patient and what an amputation can do to the patient. And you see there that when you're looking at the 5-year mortality, if you have a major limb amputation, such as a below knee amputation, your 5-year mortality increases, and it's just below lung cancer. So you should really take this. This is what I tell my patients, that you are at a risk of losing your life if you have a below knee amputation. Now, I'm not saying that you don't need one. I'm not saying that eventually you won't get one. I'm just saying that if it's possible to save this foot, it's worth the chance in doing it, okay? And you can see the cost of what it costs the United States comparing the cost of cancer in the US. And you can see that it's much more treating that. Oh, okay. Okay, so efforts in non-reconstructive and reconstructive efforts should be exhausted prior to that definitive amputation. And that's basically what we're saying. But what is the gold standard still? It's your total contact cast, right? So for those patients that have an ulceration, this is what's the gold standard for treatment. So untreated, poorly controlled deep infection is considered an important contraindication to TCC. Those are most of the patients that I see, a deep-seated infection, right? It can lead to soft tissue breakdown, deterioration of the foot. And a lot of people don't like to wear them, right? They find it cumbersome. Having to go in there weekly for a change in these is very tiring, not just for the patient, but for the physician themselves. And a lot of centers just don't have the things required in order to put them on, or the time required in order to put them on. Yes, there are simple ways to do it. There is the easy TCC, but I haven't been able to get it in my facility. I really haven't. It comes and goes. Some reps come and goes. It's very difficult to have these things in an entirely Medicaid population. So even though it's the gold standard, it is difficult. So here you have, there is also a high incidence of recurrent ulcerations associated with Charcot foot. This is what we said. But in this JFAS article in 2018, you see that long-term effects Charcot foot they tried to see what were the long-term effects of Charcot foot in patients treated with early weight-bearing in a removable crow boot, okay? It was an 11-year, 3-month study. Patients were treated with early weight-bearing in first a total contact cast and then weight-bearing with a crow boot, which they wore up to when they reached Eichenholz stage 3. You have 62 patients with Charcot neuroarthropathy. Overall incidence of lower extremity amputations, 25.7%. And 11% of those had major amputations. So there was an incidence overall of 64.9 greater in diabetic foot ulcers than described for regular diabetic patient population. So in conclusion, conservative treatment of Charcot foot, they found, with early weight-bearing in TCC followed by removal crow resulted in a relatively high incidence of another ulceration and lower extremity amputations, with the incidence of lower extremity amputations greater in those people that had a hindfoot Charcot, which we can understand, right? A more unstable foot, and manifestations compared to a midfoot Charcot, okay? So, but guess what does work? Reconstruction. So here you have an article, 2020 Albright. They tested the cost effectiveness of reconstructions compared to its alternatives, right? 3 different types of scenarios were compared: reconstruction in patients with no foot ulcer, reconstruction in patients with an uncomplicated ulcer, and then reconstruction in patients with an infected foot ulcer. And what they found was that Charcot reconstruction was more effective strategy in those uncomplicated ulcerations or no ulcerations. So what does this tell us? To me, it kind of says, if you see the deformity, then you should find a way to fix it, right? A deformity that is about to cause a complication, correct? Not everybody needs surgery, but if it's something where you see a thick callus, you see a blister, you see somebody that keeps on opening up, it's more important to fix that deformity sooner rather than later. So in conclusion, this is what they found. Amputation may result in lower upfront cost. It does not prevent the patient to re-ulcerate or ulcerate on the other side. Patients are also less likely to walk independently even after recovery from an amputation. And those treated conservatively with bracing still have an unstable joint at any point could break down and develop an ulcer. So evidence suggests that patient quality of life improves following reconstruction. A return to walkability and function has been noted in reconstruction patients as well. Here you have another study, a 5-year follow-up after a patient had reconstruction surgery. Evaluate of short musculoskeletal assessment examination patients with Charcot neuroarthropathy before and after reconstruction, and results were the mean values for all variables measured with those short musculoskeletal assessment examinations were improved at 5 years when compared to those preoperative values. So once again, reconstruction did better than none. But what type of reconstruction are we doing? Because you don't often know, right? Are we doing a midfoot fusion? Are we doing an ankle fusion? When should we do what type? And it might seem easy. But first, we need to ask what kind of Charcot we're talking about. So here you have a case that I'm going to show you first, and then we're going to ask you again at the end what you would do. So 59-year-old male presented to the ER, history of fall back in 2019, but this was in September of 2023. So that was just a secondary history. No recent history of trauma. He just stated that his foot started getting swollen and red with really no significant trauma that he noticed. X-rays were taken, a CT scan, and a cam boot was ordered for the patient. And the treatment for the patient in the clinic was an OODA boot for the swelling and non-weight bearing. Right, which you can probably do, right? If you don't see the x-rays right away, or if the patient's gonna go get x-rays, listen, I don't know if it's broken or not, but I'm gonna put you in a new boot, and you need to be non-weight bearing. So this is the CT scan that was done in October of 2023. So he came in September of 2023. Here we are in October of 2023. And his past medical history, you can see that there. But you can see that his A1C is not really the best controlled, right? It's in July of that same year, it was 9.0. That's kind of high. And in November, it's even higher. Okay, so we really try to see what's happening here. So this is October of 2023. So initially, when you saw those X-rays beforehand, yes, you definitely saw the midfoot breakdown, but if you take a closer look at the CT scan, and I'm just going to go through that one again, you see small speckles in the ankle region, definitely destruction of more than half of the talus, right? So if you're planning to put midfoot beaming on this patient, which if I had just looked at the X-rays, I would probably be planning that too. I would be at a high risk of having, I believe, avascular necrosis of that talus, right? Because you really only have that body that is holding any hardware in there, okay? Okay. So this is what it actually looked like when he was referred to me, right? Even further breakdown. And so we take weight-bearing views of the ankle and of the foot. And you can see, well, the talus is still within the sulcus, but if you look at that Mortis view, you can see there's an osteochondral lesion already forming at the in the medial aspect of the talus, right? And you can see how much destruction has happened in the midfoot. And that talus, to me, that really doesn't look like it's healthy, right? No ulceration, all right, and lab values are normal at this point. And he does have a history of having surgery on the other side for an IED and a graft application. Okay, so let's keep going. So here you have your anatomic classification systems that we usually use for seeing what type of Charcot we have, what joint is affected. And, it really kind of tells us which ones we're treating and how common they are. So in this lecture, we're kind of focusing on the Sanders and Freiberg's pattern 4 and 3. And in the Brodsky classification, more of like a 1 and 2, really. And this is a closer look at that. So what's joint should fuse? Well, what we know is that we really want a super construct, right? We want something really stable that the patient can walk with without having the risk of breaking down, right? And so this requires bone resection to be carried out, allowing for adequate deformity reduction without affecting the large soft tissue coverage tension. I mean, sometimes they don't have that much soft tissue covering things, especially if they have large ulcerations. But you want the strongest construct that can be tolerated by the surrounding soft tissue envelope. And the user's constructs that can be placed in a position that allows for maximal mechanical function, right? You want them to be able to walk. I mean, that's the point of reconstruction. So what do I usually see? And let's take a look at this midfoot Charcot. So I see a negative Meary's angle, decreased calcaneal inclination because, the root of all evil is the Achilles tendon. Increase in talar declination angle and a cuboid equinus. You can see that cuboid just popping out the plantar aspect, and that's why you have, usually you have an ulceration in this region. So here in this particular patient, you can see subluxation at the Lisfranc joint. Right? And so the medial cuneiform is just hanging out. And then a homolateral dislocation of the sphincter. You don't always have that. You can have a dorsal dislocation, right? It doesn't have to have a homolateral dislocation, but this is usually what you have, a rocker bottom deformity and an ulceration on the midfoot. So what do I usually do? I do use midfoot beaming for these kind of things. So this is, again, your standing x-ray. And then this is what it looks like post-operatively. So you can see there the beaming screws, one from the medial column. I use one also from the second metatarsal to the talus and subtalar joint, and then from my calcaneo to the cuboid joint. And you have to resect all the joints because really you don't want a non-uniform, and you want to make sure that you're getting proper fusion of these joints. So this is what it looks like on the AP. And that's what it looks like in the lateral. I kind of changed a little bit of where I put my second met screw. I kind of started at the base of the second metatarsal and go all the way to the calcaneus, as was discussed in Grant's article in 2022. But how about the hind foot? You're right. You have incongruity at the tibio-talar joint. I always ask for weight-bearing X-rays unless I see something like this where there's an obvious incongruency in that tibio-talar joint. And then you have supination or pronation of the forefoot, severe valgus or varus of the calcaneus, severe calcaneus equinus. If you see the talus, you have usually a severe declination. And why I say if you see it, it's because sometimes it's destroyed, so you won't see it. And the ulceration can be around the ankle or even plantarly, right? So in this patient, that ulcer was plantarly right underneath the talus. So how to fix it? You can do, usually you try to get an tibio-talocalcaneal fusion if you have a talus. If you don't have a talus, and then it's your tibio-calcaneal fusion. And so you can do it a slew of different ways, but you want a fusion of this joint. So here I've tried several different modalities to do so. But what seems to be the problem when you try to fuse everything, right? You need to have an appropriate alignment, use the strongest construct that can be tolerated with this roughness of tissue, and then use the constructs that can be placed in a position that allows for maximal mechanical function. That's what we said from that article. So you want the patient to walk. But having a pantalar arthrodesis, sometimes can lead to failure and increases stress on the back of the hip. So here we have that same patient that we had initially in that slide, and this is what her films look like, right? Complete subluxation. That talus is probably dead, right? So I don't know if I would really want to use that in my fixation because, first of all, she did have that ulcer there, so it's probably infected, chronically infected. So here's what we did. We put an external fixator on, we took out the talus. And then we came back afterwards. We actually performed Masquelet technique. If you don't know what Masquelet is, I actually took out the talus. I put in my polymethyl methacrylate spacer within that joint, made sure that all the cultures were clean, and then I came back afterwards to have my fixation. And this is what I did. And I wanted to fix everything. I wanted to have that stable foot so that she wouldn't move. And so this is what it looked like initially. And she ended up doing really well. And this is what her AP view looked like. And so this might look really good, but look at that. She's already getting that motion inside there, and it's making small sclerosis into the tibia immediately. And I have her come back every year, and she's still okay. But I'm just waiting. I'm just waiting for that for the other shoe to drop, right? And that's her. So what I do now recently is more of what's called the flipper foot. So what is the flipper foot? Basically a hindfoot or ankle arthrodesis that provides a stable ankle joint with motion segment in the foot to allow the patient to walk with a better functional gait and prevent further breakdown in the limb. And a lot of us instinctively do this already, but ACFAS a couple of years ago, Loveland et al. Actually had case presentation where they worked up 35 patients and they did a 27.5-month follow-up. All the patients had the Achilles tendon lengthening, hindfoot arthrodesis, midfoot osteotomy. And I swear, I know I'm out of time, but we're going to go through this last bit really quickly. So in their outcomes, 24 patients had a tibiocalcaneal fusion, 11 patients a tibiocalcaneal fusion, the first one, 24 tibio-talocalcaneal fusion. And you see how they did it. They used ORIF, ORIEF, and then they placed everybody in those fibular nails. And they had 89.2% fusion rate. 5.35 developed non-union, and the average time to fusion was 17.1 weeks. And there were no limb loss in the series. So what is so great about this? Well, do a posterior muscle group lengthening, a hindfoot fusion, a midfoot osteotomy. Oh, this was my other patient. So this is the first one that I tried this on, okay? So he had a talar fracture that developed avascular necrosis, and so this is what it looked like afterwards, right? You can see all those screws there from them fixing that talar fracture. And you can see that the ankle is completely gone, right? And they waited the adequate amount of time to have the patient weight bearing after 8 weeks. So this is what I did. I did a posterior muscle group lengthening, hindfoot fusion, midfoot osteotomy with a small wedge resection. I used both internal and external fixation. And I do this thing called a tibial lengthening in those patients where the talus is completely gone. And I feel like they need adequate length in order to be able to walk evenly, All right, I feel like if they're putting more pressure on the other side, there's more likelihood that they'll break down in that lower extremity. And I've seen bilateral Charcot deformity, so I know what that looks like. So after doing all that, this is my patient. He's wearing hokas, and this is him weight bearing right after surgery. Of course, he's the adequate 300-pound patient. That you'll see, but he did really well, and he follows up now every year. Okay. So here you have one last case, severely plantar flexitalis with a fragmented navicular. Here you have what her x-rays look like. Now, I think in like maybe 5 to 6 years ago, I would have tried a beaming on this, right? But she has a history of an ulcer underneath that cuboid. Who knows how long that has been there? The patient's podiatrist has tried to heal that for a long period of time. So this is all the surgery that we did: posterior muscle lengthening, ankle joint resection, fibular osteotomy to go through the ankle, midfoot osteotomy, frame application. And we did make sure that that midfoot was not infected before we came back for our last treatment. Okay, here we go. I'm almost done. Here's my surgery. That's after my posterior muscle group. I resected the ankle joint. And this is the internal fixation that I put in initially, and then I put on my frame. I make sure that everything is properly reduced, and then my frame application. And then I do let them weight bear with the frame. They're able to go home as long as we have determined that they have no osteomyelitis. And so this is what she looked like afterwards. And then we came back in another 3 months, again, making sure that all the labs were negative, and we put in internal fixation. Okay, let's skip this case because we're running low on time. Okay, so in the end, so what is my criteria? Severely plantar flexitalis, dorsally displaced or fragmented navicular, a revisional Charcot midfoot that has failed the beaming, all right? And an ankle Charcot where primary fusion is a must. That's when I do my flip-foot construct. And you see that the patient afterwards does have adequate range of motion, but the motion is happening in the midfoot. But the patient doesn't care. The patient just sees that they have a good motion in the foot, and they're able to put their shoes on and weight bear. Now, I don't let them put their shoes on right away. Obviously, we have to wait for the swelling to go down. There is some period of them needing some secondary bracing, okay, even an Arizona brace. But this is what it looks like. So all the patients are able to move their forefoot. They've had a slew of different types of amputations from cases in the past. And that's it. So in conclusion, diabetic foot ulcerations caused by Charcot neuropathy is a surgical and medical emergency in which time is not a luxury that these patients have. Quality of life increases after reconstruction. The flipper foot can give patients more functional gait and can decrease further breakdown. And a return to walkability is what these patients need to return and increase their quality of life. And thank you so much.